Good day, ladies and gentlemen. Welcome to another lecture. This is Bio 202, Anatomy and Physiology, and you are with Dr. Ben Pandit. Okay, welcome. I hope you are doing well. So today, this lecture is going to be about the kidney, yes, the urinary system. Let's get into it, shall we? Let's jumpstart you with this. What is the world record of urine in the bladder? Actually, they come up with this kind of accidental find. So the person actually have problem and a whole bunch of other things, and when they start draining the bladder, this is what they found out. Just keep in mind that normal folks like you and I, most people, actually pee out about 1.5 to 2 liters of urine a day. 1.5 to 2 liters of urine a day. So this is quite astounding when the medical personnel actually found this out, saw this in the hospital. So the answer is 22 liters. 22 liters. So that bladder must be huge. It's like a size of a basketball. I mean, you have to stretch that much to actually hold 22 liters in your bladder. So imagine that, to hold 22 liters. That's 11 of that Coke bottle, that 2-liter Coke bottle. You have 11 of that inside your bladder. Oh my. Okay, it must be huge. True or false? The smell of urine can detect medical illness. And the answer is yes, it's true. Yes, you could detect all these things. Like if you smell ammonia is indicator of dehydration. That means you're not drinking enough. If you actually have a musty smell, that means you have a liver disease. If you have a foul smell, that means you have bladder infection. If you have a sweet smell, that means you have diabetes. So the smell of your urine could tell a lot of stories. So you might want to smell that urine every now and then. It might tell you what might be going on in your body. So don't just flush that urine down. Just take a whiff every now and then. Okay, so first one, you guys definitely need to know this. This is the function of kidneys. Again, kidney, you just think just letting things out, letting things go, but it's not. It actually does a lot more than that. Not just excretory, but also filter your blood. Your kidney actually play a important role in terms of bringing stuff back to your body as well, and bringing stuff then back to your plasma. Regulate blood volume. Okay, that's mean osmolarity and pressure. We talked about that before. Kidney actually control your blood volume, which also kind of lead to the next point, is secrete the hormone like renin, right? Renin, we talked about renin before. EPO, that's a hormone to help with your making your bone, if you don't remember from the hematology. When we talk about hematology, that's when EPO is where kidney actually leads to make more bone marrow. Okay, not making your bone, but making your bone marrow. Your bone marrow would actually make like your red blood cells and white blood cells, all of those things. That's what I meant. So the EPO is actually help your body, your bone marrow, to produce your red blood cells and your white blood cells, and it's all of it caused by your kidney. Kidney has to be the one to tell your bone to do it. Okay. Also regulating your acid and base balance. That's where you have your pH. If your pH is low or high, your kidney could actually regulate that as well. Easy mnemonic to remember is a wet bed. A wet bed. Acid-base balance, water balance, electrolyte balance, toxin removal, blood pressure control, erythropoietin, EPO, and vitamin D. That's one thing that was not mentioned on there, is also control your vitamin D absorption, metabolism. Okay, that's for your bone. Okay, waste filtered by kidney. These are the three things that you want to know. any of these three: urea, uric acid, creatinine. You don't want any of these to be high in your body. If you actually take out your blood and you actually see any of these actually high level in your blood, it's gonna be, oh no, oh no. This is basically, if this goes up in your blood, it tells us that something is wrong with your kidney. Let's look at your kidney. That something's wrong. If your BUN, your blood urea nitrogen, goes up, that means something is wrong with your kidney. Your kidney is not processing this urea. Same thing with your uric acid level in your blood. If that goes up, that means something wrong with your kidney. Creatinine should be very, very low. And if it goes up, again, it's have some problem with your kidney. Your kidney has two, let's see, your kidney has two layers. Right here is one. Oh, two. Let's, okay, so your kidney has two layers. One is here, which is called the cortex. The cortex is from the renal capsule, which is the edge of the kidney, to the top of these pyramids. All of these pyramids. Just imagine a line. If you could think of a line, okay, you think of a line, this line right here between the pyramid, all of these pyramid and columns, okay, this line. So you have the cortex here, this area here, and you have the medulla here at this area. Okay, so let me put in a different color. Maybe you might see a little bit better. So put blue. So this would be the cortex, and these would be the medulla. Okay, so the cortex is just on the top. Okay, on top here. And your nephrons are actually in your cortex. All of your most of your nephron, not all, but we'll talk about that. A few is in cortex, but they're part of them actually down onto the medulla, onto the medulla area. So renal medulla is just think of medulla is middle, so M for middle. So it's the middle part of your kidney, okay, the middle part of your kidney. So the medulla consists of your pyramid here and also the column, renal column, which is here. So you have pyramid, column, pyramid, column, pyramid, column, pyramid, column, pyramid, column, pyramid. So those are the renal medulla. Medulla is the area. People oftentimes confuse and get those mixed up. So the medulla is the area. In the middle part, so medulla, middle, and then cortex is on the outside. Okay, cortex, cord on the outside. You have this cord on the outside. Okay, so the cortex outside, medulla, middle. Okay, and you have in medulla you have the pyramid, renal pyramid, and renal column, alternating ones after the other. Okay. As you can see, most of the nephrons hanging out in the cortex. You could see right here, the nephron actually just hang out in the cortex. There are few nephrons that actually kind of go all the way down to the medulla layer. Okay, a few of them that goes down to the medulla layers. This is something to note, and actually you will see this on your exam. So something to note, this is the blood flow. Yes, I know you guys love blood flow. This is a blood flow that into the kidney. Again, this is going into the kidney, not coming out. Okay, so you're going to have the renal artery, which you should know by now. Renal artery, that's the first one. Then it go to segmental, interlobar, arcuate, interlobular, so do not mix this up. So this is interlobar, is between, inter means between the lobe. Okay, interlobar means between the lobes. And this one is interlobular arteries. That means it's actually deeper into the little lobule. Lobule is a smaller lobe part. Afferent arterioles, and then you get into the glomerulus. Okay, afferent means going in. You have afferent current, you're going into that current. Okay, so glomerulus is the part of the nephron, which we'll talk about shortly. Okay, so remember this pattern, and this pattern actually will repeat itself when it comes out of the kidney. Okay, so this is when it's coming out of the kidney. You have the glomerulus, you have efferent instead of afferent. You have efferent, peritubular. That's the only one that will be different. Peritubular capillaries, and then you go into interlobular, arcuate, and interlobar veins, and then renal vein, and then back to IVC. Okay, so should know these. You have two of them, one going in and one's coming out. Okay, should know these. You welcome to use the mnemonics and whatever might help you to get through these. Just be able to remember the name. Okay. The nephrons are the key units of the kidney. So when we talk about the urinary system, you need to know about nephrons. You definitely need to know about nephrons. Okay. Majority of the nephrons are in the what we call cortical nephrons. Guess where do they live? Cortical nephron, most of them live in the cortex, right? Cortical cortex. Look at this right here. Most of them are actually inside the cortex. Only like tiny little tips there. That tiny little tips actually dips into the medulla level. Okay, that dips into the medulla level. So majority of them, 80% of them, live and happily make cortex their little tiny nice home. Okay, living just fine in the cortex. So 80% of them, they usually have a short loops. They have this short nice little short loop. Okay, and these guys produce most of your urine. The other one is juxtamedullary nephron. That means these nephron, instead of being in the cortex, they're in the medullary. So juxtamedullary, that means living in the hood, living down and under in the hood with the medulla. Okay, living in the hood with medulla. That's 20% of them that does that. Okay, so the loops, they go deep, yes, deep into that medulla. Take it deep, medulla, just take it. So deep inside that medulla, you have these juxtamedullary nephrons. Okay, maintain a proper sodium level and water balance in the body. Okay, this is what these guys are doing, that maintain that proper sodium level. Look at this. You have 1 million nephron per kidney. We have 2 kidneys, so therefore you could have up to 2 million nephrons in your kidneys. Wow, that's a lot of nephron. A lot of nephron. Okay, so let's talk about the nephron itself. Okay, nephron itself. So we'll come back to these. Let me show you the picture. I'm more a visual person, so I'll rather show you the picture, what it is. Okay, and this picture seems a little complicated, but let me break it down for you. Okay, so the 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 blood that's going in right here, when it goes in right there, this is called the afferent arterioles or afferent artery. Okay, afferent arterioles, and when it's come out right here, this is called efferent. E for exit. Okay, E for exit. We talked about this shortly before, talking about different arteries coming from your renal artery going into glomerulus. Glomerulus is this guy here. Okay, this guy here. Okay, so what I want you to think of, and think of every time we talk about nephron, think of nephron as like a little snake. Okay, you have the head of the snake here, the head, the neck of the snake here, and the body of the snake here, and then the tail of the snake. and the glomerulus is what the snake is eating. Okay, just imagine a little snake right here. You have a little eye, and you put a little eye here. Okay, a little eye, and this is a little mouth that actually eating this arteries. So just imagine that's a snake that eating the arteries, and the artery that's coming in is the afferent arterioles. Going out is the efferent arterioles. So the head, we call the head as Bowman capsule or glomerular capsule. Bowman capsule or glomerular capsule. I believe the terms is here, glomerular capsule, Bowman capsule right here for you. So this is the head of the snake. What the snake is eating is called glomerulus. Glomerulus. Okay, glomerulus is what the snake is eating. You have the afferent arterioles coming in and the efferent arterioles going out. A for going in, you get E for exit coming out. Okay, so next part of your snake head is called the PCT, proximal convoluted tubules. Proximal convoluted tubule, which is right here. Okay, so the neck of the snake is the proximal convoluted tubules. Then you have the body of the snakes. Body of the snake. You have the one going down, which is called descending loop of Henry, and then one going up is called ascending loop of Henry. Okay, descending and ascending loop of Henry right here. Loop of Henry, not a normal Henry spelling, but just kind of Henley, 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 Henley. Okay, so Henry. So that's the loop of Henry. You have coming down and going up, descending and ascending loop of Henry. The tail of the snake, if there's a PCT, proximal convoluted tubules, we must have distal convoluted tubule. Okay, so this is away from the head, must be called DCT, distal convoluted tubules. And then you're going to go into this guy. This is called collecting duct. These are your urine paths. So you have the blood paths right here. Your blood paths are coming in. Okay, and we're going to talk about this whole process. So the blood will filter out everything, all the water, all the solute, and everything dumps into this nephron. And what the purpose of the snake is? The purpose of the snake is reabsorb water. It's going to reabsorb your nutrients and water back into your body. And the rest of the waste goes out into the collecting duct and goes out into the nice little river or dirt or restroom toilet or the johns that you put it into, wherever that might be. Okay, so you have all these terms for nephron that you definitely need to know. You're going to be tested for your lab and for your lecture. You need to definitely know these terms. Okay, first again is glomerulus. This is where it's coming in, where the filtration occur. We're going to talk about that term. Filtration occur here. Okay, and then you have glomerular capsule, which is the Bowman capsule. This is where all the parties going into the nephron, all these entering. So think of the head of the snake. This is where things are entering into the whole entire, the rest of the body. Proximal convoluted tubules, that's the first part of the neck of the snake. And loop of Henry, that's the U shape coming down and going up, descending and ascending. And distal, and then collecting duct. Okay, we're going to talk more about this in detail, definitely detail. This is the flow of the urine. You definitely should know the flow as well. Start from your glomerular capsule or Bowman capsule. Then you go into proximal convoluted tubule, the loop of Henry, descending and ascending. Distal convoluted tubule, collecting duct, papillary duct, minor calyx. So now we're talking about these are the right here. So the loop of Henry, remember the nephrons are here in the cortex. Loop of Henry goes down a little bit, and then now you're going to go into the collecting duct, the papillary duct, which is right here. So renal papilla or papillary duct, same thing. So renal papilla, papillary duct. You have the minor calyx here, major calyx here, renal pelvis. As we're going down the list, Ureter, urinary bladder, urethra. This is right before it comes out. Some people actually get these two mixed up. Okay, I did. I did. Yes, when I went to school, I get these two mixed up all the time. Which one come first, ureter, or urethra? Which one come first? So I get these mixed up all the time until I find out a little secret. When you go to the bathroom and you pee, you go so it's urethra. So it actually helped me remember that urethra is right. It's coming out to the toilet, to the field, the ground where were you shooting that stream. Okay, so urethra is right before it comes out. Urethra. Okay, or ureter is actually entering the bladder. So ureter entering the bladder. Okay, so think of it that way. So here is a key concept for your nephron. Okay, key concept for your nephron. So first you have that filtration. The filtration occur in that glomerular capsule going into that snake head. Okay, that filtration. The rest of the body of the snake, okay, the neck, the body, all of it is reabsorption and secretion. Okay, reabsorption, making sure that stuff going back into the blood. Secretion, things that you don't want, you want to get rid of it. Let's get rid of it. Okay, get rid of the waste. And then water conservation. Your kidney does do a lot with water conservation. Okay, reserving that water back into your body. We're going to talk about that shortly. So filtration, plain and simple, this is the easiest and plain and simple that I could put. Okay, your blood filter out just about everything. Okay, all the little things will come out. Okay, just realize that anything big, anything you have this afferent and efferent flow. So this is technically your capillaries. This is like your blood vessels. Okay, anything big, huge, like your red blood cells, kind of stuck there, cannot come out. Anything huge like your white blood cell, huge. These are huge molecules. They cannot come out. Your platelet, relatively small, but still too big, way too big. Okay, way too big to come out. So your platelet, your red blood cells, your white blood cells, all those big players, huge player, cannot come out. They cannot come out from there. They have to stay inside your blood. The rest all come out. The rest all come out here. Okay, all come out and drain into the snake itself. Okay, so filtration, just think anything big and huge cannot come out. Protein is huge. The big part of your protein is actually a folding part. It looks like little folds there. You have folds of protein cannot come out. Okay, the smaller part of protein, like amino acid, can come out. That's the very tiny little protein. Tiny little protein that can come out and play. Fat, oh, no way, Jose, is huge. Fat is huge. So fat cannot come out. So anything big, stay inside. Okay, stay inside. All the little things come out. Okay, so that's what filtration is about. Filtration, you do need to know this. Okay, you do need to know this. I will emphasize this over and over again. You need to know this page. There will be several questions actually asked you on this page alone. Okay, several questions on the exam that will ask you about this page alone. So one is called fenestration. Fenestration is the big holes. Just think of things that blocking large particles. Things that blocking large particles do not let large particle comes out. And you have these basement membrane that's kind of picking up smaller stuff like your protein. Okay, is the basement membrane, and you have these slits, filtration or glomerular slit. This is where you kind of letting, kind of like a little tiny vent, but still won't let big things come out. So you have these. Okay, so you could see the slit right here. The slit. Think of the slit is like a the outside gate. This is the last filter. Think of all this as a layers of different filters that you see. Okay, layers of different filter that you see. The first one is the um, fenestration. Fenestration is just holes. You have these like holes like strainer. If you think of strainer for your kitchen appliance, you have strainer. You actually have a lot of holes in them. You pour water in it, just come right out. Okay, so these literally just work against like huge particle like red blood cells, white blood cells. These guys cannot come out here. Basement membrane, this is, think of like a sheet, a thin sheet that wraps around that actually become like a filter paper. Basement membrane literally filter out just the small stuff. Anything big cannot go through. So you could see how big holes here, right? And the pink part is the basement membrane that literally just fine filtering. So you have these, think of it, you put it next to the cloth, the sheet of cloth, white cloth, to kind of strain out any big huge particles. And then the last one is the slit. The slit just make it harder for things to come out, but it's more like a vent, like the end of the vent. If you look up your vent, you have these little slit in your vent where the your AC come out. Same thing. This is where the last filtration actually happened. Okay, last filtration that actually happened. So this is what glomerulus is. You have these three layers. You have the fenestration, basement membrane, and the filtration slits. Those actually help filter things out, filter huge stuff out. Okay. GFR, this is the glomerular filtration rate. So this is how fast, how much you filter out stuff. On average, okay, on average, look at this. Your body filter out 180 liters a day. 180 liters a day. Yes, you do need to know this. 180 liters a day. If you notice, all the red stuff that I actually highlighted is something that you probably need to know. Okay, go back and watch all these pages again. I highlight the red stuff. That means you definitely need to know those things. Okay, and you only pee out 1 to 2 liters a day, 1.5 to 2 liters a day. What does that mean? That means you reabsorb 178 liters of those a day. So you filter it through. You filter all of this water and stuff through your glomerulus 180 per day. But when it's all said and done, when you pee stuff out, you only pee 1.5 to 2 liters a day, which means the rest of your nephron, the main job is to reabsorb all of this back. Reabsorb 178 liters of stuff a day. So see how hard your kidney is working. Kidneys are working each day. They actually are really hard working dudes that just reabsorbing stuff back for you all the time. As you're sitting and watching this, they are working hard to reabsorb all those stuff back. Okay, so you don't need to know this. I don't definitely want you to know the coefficient rate and all of this stuff. Okay. Oh, one thing I do want to mention is, as we get older, guess what? Your GFR, is it getting better or getting worse? As we age, your GFR is getting worse. Okay, your glomerular filtration rate. And if you are lower than 50, okay, your GFR is lower than 50, that means you have a chronic kidney disease. Okay, chronic kidney disease. So oftentimes we actually monitor you for this. Why? We just measure your blood, and we could actually calculate and know exactly what your GFR is just looking at your blood alone. And if your blood is showing that you have lower and lower level of GFR, then we would recommend that that you might have a kidney problem. And if you are lower than 20, that means you definitely are a good candidate for dialysis. Okay, good candidate for dialysis. Okay, so increase GFR. If you have more stuff going through your filter, definitely you're gonna pee out a whole lot more. If you don't have a lot of stuff going into your filter, then you're gonna retain a lot of waste. So you're gonna get sick. You're gonna get really sick. You're gonna look sick, not in a like cool sick way, but you definitely gonna feel sick. Okay, so I don't recommend that. It's not a trend. It's not a good look on you, so make sure you drink enough water. Speaking of water, can you drink too much water? The answer is yes, you can drink too much water, so make sure you don't want to over drink it. If you drink too much water, you could actually damage your kidney, you could damage your GFR, you could damage your nephron. So too much water, what is too much? Too much is if you drink like 5 gallons of water a day, that's not good. That's pretty much you drink the whole entire cooler. That's a 5 gallon bottle of water in your office or at work. That's not good. So if you drink that much, just kind of kick back a little bit, just chillax a little bit. Chillaxing, don't drink that much. Okay, 2 to 5 liters is pretty good. Okay, in terms of your water drinking per day. Okay, myogenic mechanism. This is how your body auto-regulates. Okay, the nephrons. This is so they're looking at the afferent coming in. Okay, and if the afferent arterial stretches, make it become bigger. That means you have increased your blood pressure. You increase your blood pressure. Okay, if you have high blood pressure coming in here, it will detect by the stretching of these afferent arterioles. When it stretch, then your kidney will automatically release some hormone to actually cause to help to maintain your blood pressure inside your glomerulus. Okay, to maintain the blood pressure in there. So your kidney oftentimes kind of monitors the pressure all the time with these blood vessels. Monitor how much pressure you're going into that kidney all the time, and your body will go into this sympathetic control of the GFR. And sympathetic is fight or flight, fight or flight. Okay, you have these nervous system that you regulate your kidney and other organs as well, your heart, your lungs, your pupil, all of these organs based on fight or flight. And if your afferent arteriole is constricting, that's actually showing that you actually have a higher pressure, your higher blood pressure, and your body will respond. Okay, by going into that sympathetic mode. And we talked about this before. We'll talk about the hormone control, your GFR. When your blood pressure went down, then you actually have the renin kicks in, going to bind with angiotensinogen made from the liver to make angiotensin 1. Angiotensin 1 then goes to your lung, combined with ACE. And ACE then converting the angiotensin 1 to angiotensin 2 then goes to your adrenal gland. Adrenal gland then makes aldosterone. Your aldosterone vasoconstrict your blood pressure, increase your blood pressure, and also aldosterone cause your kidney to retain sodium and water, causing your blood pressure to also go up. So all of these we talk about, I hope you still remember them because you may see them in your final exam. Okay, don't forget them just yet. True or false? Pee on a jellyfish sting will heal the wound. Okay, true or false? The answer is false. People kept saying that pee on the jellyfish stings actually would help, but it's a myth. It's not true. You could pee all you want. You're still gonna be feeling that burn. Not the Bernie Sanders, but it will burn on your skin. Okay? And in fact, by peeing on it actually makes it worse. You actually will feel even more because it's an acid. You have uric acid on your in your pee gonna cause you to actually have that wound become even more infected because you put more bacteria and waste of your body onto your wound. So please do not pee on someone jellyfish wound or even yourself. You try not to aim yourself or pee on yourself. Some of you might be very talented trying to pee on yourself on the jellyfish wound, but let's not do that. Okay, just get to the ER and we'll take care of you. True or false? Urine can whiten your teeth. The answer is true. Actually, back in the ancient time, the Renaissance time, the aristocrats, the higher or well-educated folks tend to actually use urine to gargle their, every morning with urine. It actually whitened their teeth, and it actually you have this uric acid in the urine that cause your kind of bleach your teeth a little bit, kind of just make your teeth really white. We don't have to do that these days because we actually put that. We don't put your urine in the toothpaste, but we put something similar to that uric acid into the toothpaste, cause your teeth to be a little bit whiter. Okay. Okay, let's talk physiology um, of the nephron. Okay, let's talk about physiology of the nephron. Um, mm-hmm. So the first portion, let me show you instead of that. Okay, so instead of talking from this slide, let me show you another picture. Make it a little bit easier for me to talk about this. Okay, so this is the uncomplicated picture of the nephron. Kind of stretch out a little bit, make it a little easy. You can see nice and easy. The head of the snake, the glomerulus. So you have the afferent arterioles. So afferent arterioles is AA here coming in. The efferent arterioles is going out. So you have the glomerulus, the Bowman capsule, or glomerular capsule, either one. The neck of the snake, you have the head of the snake, the neck of the snake here, which is PCT, the loop of Henry, the descending and ascending loop of Henry, DCT, distal convoluted tubule, and you have the collecting duct. Okay, so all of these are here. So let me talk about the next few slides on here. Okay, so we talked about filtration already. We all actually mentioned about filtration. This is different layers of the glomerulus and how all the stuff actually comes out. Okay, only big things, big huge stuff stay in. Your protein, huge protein, red blood cells, platelet, white blood cells, all of those huge things stay in. Your fat staying in. Okay, stuff that come out. First, remember all of this has to do with reabsorption. Okay, they're going to focus on reabsorption. You're going to see that term all over the place. So you're going to do the filtration. The first place, you're filtrating out everything. Okay, just you don't have to list them, just know them. You filtering out everything. The second part, which is your PCT, which is right here, your proximal convoluted tubules. Couple of things you might want to note. The reabsorption of water is everywhere. You have reabsorption of water every single of these steps. Okay, we're gonna mention all of these. Just know that your water reabsorb back everywhere. Remember, you filter out 180 liters of water a day, and then you have to reabsorb 178. So definitely water will be reabsorbed everywhere. The key things to remember on here is this one, PCT, is where you reabsorb glucose and amino acid and bicarb. Okay, glucose, amino acid, and bicarb is all of this here at PCT. So when you think of PCT, proximal convoluted tubules, please remember glucose, amino acid, and bicarb. This is where we reabsorb things back. Okay, we do get rid of uric acid and other organic acid here, but the key thing to remember, a huge thing to remember, is your glucose, your amino acid, and your bicarb going back here at PCT. Okay, so this is the first bus stop. Remember, so you have all these fun stuff coming down your first bus stop. Think of a bus stop. All of these folks get off the bus. You have the glucose getting off the bus, amino acid getting off the bus, getting back into the blood, and you have bicarb. Um, bicarb is also reabsorbing back into your blood. If we don't reabsorb the bicarb back, you actually going to become um, acidotic. Okay, you become acidotic, or you become acidosis. So if we get rid too much bicarb, then you become acidotic. Okay, so we reabsorb bicarb back here as well. So the first stop is the glucose, amino acid, and bicarb. Get off. Bye bye. Let's all say bye bye to the glucose, the amino acid, and bicarb. Bye bye. And now the bus traveling down here. Okay. Now second stop as we go descending loop of Henry, and then we're going to go up to ascending. Okay. Let me explain from the ascending part, going up part first, and it will make sense. Just a second. Okay. Ascending part, you have an active mechanism here. You have a active pump that pumping the salt, sodium chloride, into your blood. Okay, actively. Okay, you have actively pumping the sodium chloride into your blood. Okay, so this means that this is the bus stop where you actually taking all these salt, sodium chloride, go into your blood, and now your blood become hyperosmotic, meaning that you have a lot of solute. You had a lot of these salt, very little water, very little water. Guess what? Guess what? If you have a lot of salt here inside your blood vessel and you have low water there, the water travel from high to low. Water or travel from high to low, just like waterfall going from higher to the lower part. So you have lots of salt but very little water. So the water going from high level of water here going into the bloodstream. Okay, so if you want to remember this way, as you're going descending down, you descend down, the water goes in. Okay, it's like waterfall. You're going down. As you're going down, your water going into your blood, and you do this kind of naturally, passively. You don't actually require any energy to do this because of the osmosis that actually happen, where you're going from the higher concentration to the lower concentration. Okay, this is the huge part where we reabsorb water. Huge part where we reabsorb water here. Same thing with here. The PCT is also a huge part. We reabsorb water, but this is a passive mechanism that reabsorb water right here at this point. Okay, so the descending is the water. As you go up, the salt, sodium chloride get off the bus. Okay, sodium chloride get off the bus. Actually, just think of it like they're not just getting off willingly. Someone actually pulling them off, throwing them out of the bus back into the bloodstream. Okay, just think of they didn't pay the ticket, and then now the bus driver kick them out of the bus, putting them in the bloodstream. Next stop, we call DCT. DCT, this is where we also absorb more water, but this is where I want you to remember, this is where the aldosterone, remember renin-angiotensin-aldosterone system? This is where RAS actually acts upon. You will have this question on your exam, so your RAS, your aldosterone acts on your DCT, distal convoluted tubule. Okay, collecting duct is here. This is where your ADH, ADH is from our hormone chapter. Anti-diuretic hormone, anti-peeing hormone. Your anti-peeing hormone control the water here at the collecting duct. Okay, your collecting duct has to do with anti-diuretics hormone. So keep that in mind. Anti-diuretics, collecting duct, aldosterone, DCT. Okay, Al likes to hang out with distally. Okay, Al hang out with distally, whereas ADH hang out in the collecting duct. Okay, so collecting duct, ADH, and this is where we last stopped. We collect more water. We collect all your sodium, and but also this is where we dump out. Okay, where we dump out creatinine and urine. This is where we get rid of the waste. Where we get rid of the waste here as well. Okay, here as well, get rid of the waste. So this is what I'm gonna put this chart on there for you. You could access this one, but this is what I want you to kind of remember as you go through the chapter, knowing which section of the nephron, what happened in each section of that nephron, what happened there. Okay, what each section occur. And this is what all these slide actually was referring to, is actually what happened at those section. What happened at those section, and what kind of reabsorption occur at those section. PCT, again, mostly your water, your amino acid, your glucose happen here, and your bicarb as well. As you could see, osmosis, active, endocytosis. This is the mechanics, uh, mechanics of how the water actually being reabsorbed back. Peritubular capillaries, do you know that term? Because this is where it comes out, and this is the peritubular capillaries around the nephron to reabsorb, for that reabsorption to occur, where they're going to put those water and those stuff back into your blood. So this is the peritubular stuff. Okay, loop of Henry. I kind of explained the process of loop of Henry, what happened in the loop of Henry, where you have water conservation, and then it actually works with the passively causing, reabsorbing salt on one side and then reabsorbing water on the other side. DCT has to do with aldosterone and renin, and collecting duct has to do with ADH. Okay, ADH, collecting duct. So remember those. What is the world longest time of longest pee? What is the world record time of the longest pee? So how long when you pee? How long can you go? Okay, and this is in terms of seconds. Okay, seconds. So the world's longest pee is 108 seconds. 108 seconds. This is approximately about 8 minutes. 8 minutes. Still, that's a long time. That's like eternity. You're just standing there and pee for 8 minutes. That's truly eternity. If for anyone wants to break this record, just getting older, you will definitely get to break this record. Especially men, if you have BPH, benign prostate hypertrophy, you're gonna be standing there for a long time just peeing. You're gonna see, if you ever seeing going to the mall and you're seeing all these older men just staying there like, oh, I'm already done, and you still there, and two more people, and two more people already done their stuff, and you still standing there. So next one is, what is the world record? What is the world record farthest pee? Peeing is really far, so obviously this is the men's record. Kind of biased there, but because men has the equipment to do so, women doesn't have that equipment to do so. So men definitely broke this, got this world record, and the world record is about 18 feet. Okay. This is the officially on the World Guinness Book, that I think there have been people actually trying this at home in front of their car garage and claim that they actually did for 20 feet. So you're welcome to watch those on YouTube. All kinds of crazy stuff on YouTube. So 18 feet and 3 inches, that's the official world record. That's for a person to pee that far. Okay, so this is what I mentioned earlier. I just mentioned this idea of the descending limb and ascending limb. So descending, coming down, descending, the bus get off, you actually, water gets out by themselves because of the passive things that happen. But ascending limb, going up, this is where you absorb the salts. You kicked out the salt of your bus, and you actively reabsorbing that salt, causing the permeability become less water, so therefore the water will come in from the other side. Okay, very clever mechanism. So you don't have to work to absorb water. You work to absorb salt and your electrolytes, but you don't have to work to absorb water. The water actually is a kind of reabsorbed as a byproduct of that. Okay, you do need to know this one called vasa recta. Vasa recta. So you should definitely need to know that. Blood vessel located next to the nephron loop in the medulla. Okay, this is these actually help with water conservation. Water conservation. Okay, these vasa recta. Okay, these vasa recta help with water conservation. So we do have some urea coming back into the system, and then we do get them out at the end here, the creatinine and urea at the collecting duct. But there is still some level of those in your body, in your blood. We don't get rid of 100% completely. But we do have some going through and being reabsorbed back, and then we're trying to dump it out as well. So it's a normal thing. Okay, normal thing. Collecting duct also help reabsorb water. As you go down further, it actually help more and more drawn out water. So the more you go down, the deeper concentration you have, the more water you will absorb. Last thing before we go into pathology is the bladder. The bladder. So this is the ureter coming down. It enters the bladder, which is this little shape here. You have the two openings of the bladder, which is right here, the urethra opening right here, look like little aliens right here, like little ants, alien. You have this area called trigone. Trigone, guess what? Looks like little triangle, so they call it trigone. Okay, trigone, center of the trigone. So this area is a lot smoother, nice and smooth. Like think of it like a little slide, like kid slide, or water park slide. You have these coming out here. You imagine you come down the tube like ooh, and then you go out in this little slide. Okay, you have two sphincter. Internal and external sphincter. This is why in your quizzes, with your digestive quiz, because your butt, your anus, have two sphincter as well. You have the internal sphincter for your internal anus sphincter and the external anal sphincter. And the reason, again, is the same name. And they do exactly the same thing. This one, you have the internal urethral sphincter and external urethral sphincter. Okay, internal, again, involuntary. Okay, involuntary, you cannot control it. External, you can control it voluntary. Again, so same thing, just like your butt. But that's why you need to put urethral versus anal. Then you know which one you're referring to. Are you referring to internal sphincter for your bladder, or for your pee, or you talking about your poop? So make sure you specify that clearly. Okay. So you have the urethra here. Prostate, this is for men. Women do not have prostate. Men's do. So this is for men. You have prostate and you have urethral, prostate urethra here, and then come out membranous urethra, and then woohoo, go into the toilet. Okay, down here. So trigone is this area here, nice and smooth. Okay, right by the openings of the ureter. Sorry, opening of the ureter. You have the internal urethral sphincter, external urethral sphincter. Okay. So if you cannot close this, if you cannot close the external one, guess what? You have something called micturition. That means you're dripping all over the place. Okay, that's where depends comes in. You have this little water, you have these little lovely pee coming out, like little rain, the yellow rain, the acid rain coming down your pants. So, okay. So as we get older, your external sphincter, your external urethral sphincter doesn't work. So as you get older, even as early as 40, so even 50 years old, you will start having these kind of problem where your stuff kind of leaking out. They just don't want to stay in. Okay. So we're gonna talk about a few disorder, and then we'll be done. Yay! The first one. Really would love you to watch these videos. Really amazing stuff. So kidney stone, you have several type of kidney stone, but the most common one is your calcium oxalate to be exact. Calcium oxalate is the most common kidney stone. So if you holding your pee in, if you hold your pee in, you don't want to do that because you could get kidney stone. Very common profession to have this is like actresses, people who are in court, like lawyers, because they have to be in court for a long time. Judges as well, they have to hold their pee. If they hold their pee, they can develop these kidney stone. Kids nowadays, if you actually have kids, teenagers that have drink tons and tons of soda pop, you could get this as well. You could actually get kidney stone. So you have to be careful, boys and girls, not to drink a lot of soda. Otherwise, you get these. Okay. Calcium oxalate, that's the most common one, and that's the one that you should remember because that's the one that you oftentimes see. These are calcium oxalate usually. Okay, you have screw white, which is the second most common. Third most common is uric acid, and this is only seen in people who have gout. Okay, gout. Cysteine as well, another one. If you have kidney stone, it's very painful. Okay, the official name for kidney stone is renal calculitis. Mean is in your um, pelvis, renal pelvis area. Bigger one, usually like your major calyx, minor calyx. This is where it's there. Nephrolithiasis, this is inside your nephron, so it's a little tiny, smaller type of stone that inside your nephron. Okay, so they usually have back pain. You could tap their back. You could do what we call kidney punch by just put your hand there in the back on the left or right side of their plank and just tap, and they will scream out of their lungs and trying to grab you and kill you at the same time because they are in so much pain. Okay, so you may see blood in the urine, you may see cloudy urine as well because your kidney is not working. Your kidney cannot pee. You start blocking down that pee to come out. The bladder stone, the kidney stone, they classify it. The biggest one is about a size of a softball. There's actually a picture on Google. If you actually type in the biggest kidney stone, you're gonna see a size of softball, about 2.5 pounds, pretty big. So I'm not envy at all. I do not want to have that. Okay, so depends on the group. You have dehydration. You could actually cause this kidney stone. Struvite stone commonly happen in women with UTI. Uric acid stone with gout, like I mentioned. Cysteine stone usually run in the family. And this is this is the renal calculi. These are what we call renal calculi. It's actually here, which are pretty big. Most of the time, you may not be able to pass this yourself. So what we do, sometimes we actually could vibrate it. We actually breaks it up, use these vibration to cause, to kind of break it up so you could actually pee it out yourself. Your dogs could actually have this. Well, your pet lover, your dogs, your cat could actually have this. So you might want to watch out what kind of water you actually feeding them. If you're using a tap water, there's a lot of high calcium content in your tap water, so they may end up with these kidney stone quite often, and you have to kind of tap it out or massage it out to for them to kind of pee it out. Okay. If it's big enough and it's in your ureter or your urethra, we could go in and grab it and use these. Yep, you could look. This is lovely. We'll kind of numb you a little bit, and then we would go up and then just grab it like this here. Fun, fun, fun. Okay, these are struvite. This is what the struvite look like. Look, you could see look almost like a coral, like have a little darker tint to it as well. Okay. Second disease is UTI, urinary tract infection. Urinary tract infection. Girls, you girls know a lot about this. So girls are very kind of pro about this, knowing really know all about UTI. So you have painful urination, so it's like feel like it's actually burning. Yeah, it's like you peeing out fire. You just stand there, you like peeing out that fire. You're like, wow. Women oftentimes having this. If the more you sexually active, the more you actually might have this as well. So you're gonna have cloudy urine, look like this. That means there's protein inside. That means bacterial infection. If you see this is definitely bacterial infection going on. There's a smell to it as well, foul smelling. Because of due to women's anatomy of the reproductive anatomy, it's easier for these bacteria to go up and into your bladder. Okay, to go up and into your bladder. So it's pretty easy to contract these UTI infection. One note, people often say that you should take cranberry juice to actually help with your UTI. Normal cranberry juice do not help because it actually have way too much sugar content. High sugar, that means you actually will have lots of easy for bacteria to grow. Okay, so if you really want to drink cranberry juice, you actually have to get the without sugar, which is tastes so bad, tastes really bitter. So I would recommend getting something called D-mannose. Okay, D-mannose is a protein. Oops, sorry, mannose, M-A-O-M-A-N-O-S-E, mannose. Okay, D-mannose is a protein that actually that inside the cranberries, that when you drink cranberry juice, that's what you have with these D-mannose. So what they do is they will coat your bladder, so it actually make the bacteria harder to attach onto your bladder, so you would pee all of these out. So when you start feeling that you're about to have UTI, you could start taking these, and your UTI will go away a lot quicker than without taking it. Okay. Also, another little tips as well, if you actually, those people who have chronically have UTI all the time, and you oftentimes take tons of antibiotics to get rid of your UTI, something to notice is that once you take it, please take probiotic as well. If you don't take probiotics, you're going to have other fungal infection, because when you take antibiotics, it's kill all of your bacteria. So you're going to have fungal stuff growing instead. So you may have one of the most common one that I've seen is you have sinus infection. So a lot of time, women who actually have lots of UTI take lots of antibiotics. You're going to end up with oftentimes most people think it's allergies or seasonal stuff, but it's not. It's actually caused by the fungus in your nose. The fungus become happy because there's no bacteria keeping them in check, so they just party all the time, party like 1999. So they just grow out and conquer your nose, and you actually end up with sinus infection, with running nose, all kinds of stuff. So please take your probiotics. Okay. Another one that you could have is bladder cancer. Bladder cancer. This is you have a tumor inside your bladder, which is bad. Okay. Caucasian men usually you have this when you're older as well. This is another one is called interstitial cystitis. Interstitial cystitis. This is infection, not in actually more. The symptom is very similar to UTI. Okay, everything very similar to UTI. You have painful urination, but the problem is you don't have bacteria in this one. You have very similar symptoms but without bacteria. What this is you don't have something called APF, anti-proliferative factor. Anti-proliferative factor. You don't have this. So when you don't have this, you cause yourself these what we call Hunter ulcer. You have these little ulcer everywhere in your bladder. When you have these ulcer in your bladder, every time you pee, you will feel very painful. Okay, the pee is like you wanting to pee up to 60 times a day and night. Okay, that's mean you want to pee all the time. You have this urge of peeing, but again, you don't have that much pee inside you, so a lot of time you may not even you want to go to the restroom and you sit and trying to pee, but there's nothing coming out, completely nothing coming out. Okay, so these folks, we use Elmeron. Elmeron actually is medication, but only 30% effective. Okay, 30% effective. So it's still not a good effect for this drug. Not a good drug for this disease. And a lot of time, these people who have this oftentimes have to kind of suffer through these. Another one is called glomerulonephritis. Glomerulonephritis. This is inflammation of your glomerulus. Okay, so a little different than UTI. UTI is right down your bladder, called cystitis, whereas this one is up in your kidney. So it's almost like this is your kidney infection, not your UTI. This is a kidney infection. One of the more common one that you're gonna see is called PSG and post-strep glomerulonephritis. Post-strep is when you have strep throat up into your throat here. Let's say you have strep for about a week or two, and then if you don't treat that, your strep gonna travel down, takes about a week or two, travel down to your kidney and then infect your kidney instead. So when it does, you're gonna have this Coca-Cola urine color. Coca-Cola urine color. This means you have blood in your urine. You have blood in your urine. Yes, so you see it this dark, that means there's blood there. Yes, blood. So there's a lot of blood there, and if you have protein, it's gonna be like yellowish tint, and then you cannot see through it. It has like really white color to it. You cannot see through it. Okay. Almost done. A couple more. One is renal failure. This is when your kidneys start to shut down. U/O is urine output. If you have urine output less than 500 cc or 500 ml per day, that means you have your kidney saying bye-bye. Your kidney is done. They're sick of it. They don't want to work for you anymore and they want to quit. This means you need either a new kidney or you need dialysis for the rest of your life. Okay, so this is, if it's lower than 500, that means you definitely need dialysis. There's different costs to these. There's pre-renal, post-renal, and renal itself. You don't really need to go into that. Just know that this is when your kidney is stopped working. Okay, your kidney is saying kaput, I'm done because cannot work like this anymore. I'm underpay, I'm overworked, and I'm just done. So when you are done, when your kidney is saying they are done, that's bad sign. Okay, that's a bad sign. Your kidney controls a lot of stuff. So you could see, if you see a patient who's on dialysis, you're gonna see that they kind of really lost their mojo. Their face changes color, their hair, everything kind of becomes swollen. And imagine if you have to go through dialysis, you have to sit there for 2-3 hours every other day, so two three times a week almost to go through that, and it's kind of tiring experience, even though they're just sitting there and doing nothing for 2-3 hours, but it's just tiring just for the machine to go to those places and get those done. People don't like it. People don't really like going through dialysis. So, okay. So that's renal failure for you. So take care of your kidney. Take good care of your kidney. Okay, be nice to your kidney so they could live long and prosper. Okay, that's all. That's it for this chapter. I hope you learned a few things. If you have questions, please let me know. Okay, let me know again. Send me the question. Let me know, and I'll be more than happy to explain any more of this in detail. Thank you for listening, and have a wonderful, wonderful day.